So I want you to imagine the pure chaos of a modern U.S. emergency department.
Oh, yeah. It's intense.
Right. And they rush in this 34-year-old woman. Her roommate called 911 because she was, agitated, completely confused, just not making any sense.
And she doesn't have any medical history, right?
Exactly. No past medical history, takes 0 medications. On paper, she should be the absolute picture of health. But the triage monitors are telling a completely different story.
Her body's crashing.
Her heart is racing. She's struggling to breathe. And the clinical team realizes her blood pressure is plummeting so fast her organs are they're about to lose perfusion.
Which is terrifying in a young, healthy patient.
It really is. And then, about 30 minutes into this frantic attempt to stabilize her, a nurse checks the urinary catheter bag they just placed. And, well, it isn't filled with the normal yellow fluid you'd expect.
No, it's not.
It is filled with dark, brown, almost pitch-black urine.
Yeah, that visual alone, the Blackwater combined with someone in complete cardiovascular collapse, that immediately shifts the room from a standard resuscitation into, a terrifying medical mystery.
It's the kind of detail that just stops a clinical team right in their tracks. So, welcome to today's deep dive. We're looking at your source material today, a dense clinical medical script called ICU Files, Blackwater.
It's a really intense case.
It is. And our mission today isn't just to, review a medical anomaly. We're pulling apart the threads of a case that shatters a lot of illusions about medical control. We're exploring how a common global disease becomes deadly when it crosses borders.
And how deeply entrenched medical dogmas sometimes have to be completely dismantled just to save lives.
Exactly. So how does the team figure this out?
Well, it's this fascinating intersection of microscopic biology and a massive systemic medical assumptions. To find the real culprit behind that black urine, the ER team actually has to zoom way, way in.
Right, down to the cellular level.
Yeah. Down the hall, a lab technician puts her blood under a microscope and sees that her red blood cells have been completely hijacked.
By Plasmodium falciparum, right, like the deadliest form of malaria.
That's the one.
And the initial report from that blood smear estimates that about 18% of her red blood cells are parasitized. Now, 18% sounds like a massive infection to me just intuitively.
That sounds huge.
But looking at the clinical data here, that number's actually lying to us. It's hiding something so much worse. So, okay, let's unpack this.
Yeah, let's do it.
The smear shows these specific shapes, they call them appliqué forms, where the parasite rings are kind of hugging the very outer edge of the red blood cell.
Mm-hmm.
But the lab tech doesn't see any fully mature parasites.
And that absence is actually the most dangerous clue of all. The mature parasites haven't just disappeared.
Where do they go?
They are executing a highly evolved process called sequestration. When these falciparum parasites mature inside a red blood cell, they fundamentally alter the cell's architecture.
Like a structural mutation of the cell itself.
Yeah, exactly like that. They cause the cell to express this specific protein on its surface called PFEMP1.
PFEMP1. Okay.
Right, and this protein acts like molecular Velcro. It specifically binds to receptors known as ICAM1 and CD36 that actually line the microvessels of the body's deep organs.
Wow.
And most devastatingly, they bind to the blood vessels in the brain.
Okay, I'm trying to visualize this. It's almost like the peripheral blood smear, the blood they drew from her arm, is a highway traffic camera,
Oh,
right?
I like that analogy.
It looks somewhat busy, showing an 18% congestion rate of these early-stage parasites just driving along.
Mm-hmm.
But you don't realize that all the mature, dangerous parasites have pulled off the highway.
Yes.
They've parked in the brain's narrow alleyways, completely blocking traffic and causing cerebral malaria.
That is exactly what happens. The parasitized red blood cells literally glue themselves to the walls of the blood vessels in the brain, and then they pull other uninfected cells with them in these clumps called rosettes.
So they're trapping the innocent bystanders too.
Exactly. They completely occlude or block the microvessels. So that 18% on the highway camera, that is a massive underestimate of the true catastrophic total body parasite burden.
Because the worst ones are hiding.
Right. And the most dangerous mature forms are completely invisible to a standard blood draw.
Which explains why her body is failing so rapidly. I mean, her organs are shutting down one by one. This has to be off the charts in terms of severity.
Oh, it really is. Just to give you an idea how catastrophic this is, the World Health Organization has 11 specific criteria for severe malaria.
Okay.
A patient only needs to meet one to be classified as a severe case.
Just one.
Just one. And this patient, she meets 10 of them.
10 out of 11. That is wild.
She has impaired consciousness, profound respiratory distress, abnormal bleeding, jaundice from a failing liver, severe anemia, hyperparasitemia. It is a total systemic collapse.
So she is in a coma because of the brain involvement. Now, usually if an ER doctor sees a patient in a coma with a high fever, standard medical training kicks in, right?
Yeah, you follow the protocols.
You immediately think about meningitis. You think about doing a lumbar puncture, a spinal tap, to check the fluid around the brain.
And that reflex makes total sense in a standard ER setting, but here, it is strictly contraindicated.
Wait, they absolutely cannot do a spinal tap.
Never. Because her brain's blood vessels are blocked, and she's experiencing a massive cytokine storm, which is basically the immune system's communication network going completely haywire.
Right.
This is disrupting her blood-brain barrier, causing her brain to swell violently. The pressure inside her skull is incredibly high.
Oh, I see where this is going.
Yeah. If a doctor were to perform a lumbar puncture and release fluid from the lower spine, the sudden pressure differential could cause her brainstem to herniate downward.
Meaning her brain is pushed down into the spinal column.
Exactly. It would be instantly fatal.
That is terrifying. It's like navigating a minefield where your best, most practiced instincts can instantly kill the patient.
And there's actually another standard reflex that's off limits here: steroids.
Really. Because you'd think, massive inflammation in the brain. Let's give a powerful anti-inflammatory like dexamethasone to calm it down and reduce the swelling.
It is a completely logical thought, and doctors did exactly that for a long time. But a landmark randomized controlled trial proved it to be deadly.
Wait, steroids were killing the malaria patients?
Yes, corticosteroids in cerebral malaria actually increase the duration of the coma and increase overall mortality.
Wow.
Because they suppress the very immune response that is desperately trying to repair the blood-brain barrier and clear the parasite. It went from a totally logical treatment to a strict do not do.
So we have this invisible invasion. The mature parasites are glued inside her brain, multiplying, and the medical team knows they need to kill them immediately.
Right.
And here's where it gets really interesting. For decades, right up through the early 2000s, the automatic knee-jerk drug that doctors reached for worldwide to treat severe malaria was 5-V quinine.
It was the absolute gold standard for a very long time. And to be fair, it did kill the parasites.
But there's a but.
A huge but. Hidden in the mortality data for decades was this terrifying reality. Patients on quinine were dying, and doctors just assumed they were dying from the sheer severity of the malaria itself.
Because it's a deadly disease.
Exactly. But the truth was, they were actually dying from the cure.
How does a life-saving drug secretly kill patients without anyone noticing? I mean, looking at her vitals, her blood sugar was critically low when she arrived.
Dangerously low.
Yeah, 38 milligrams per deciliter, which is a state of severe hypoglycemia. And that's caused by the malaria parasites just consuming all her glucose, right?
Right. And the mechanism of the drug is so insidious here. Quinine is what we call a potent insulin secretagogue.
Okay, break that down for us.
Sure. To understand why that's bad, think of the beta cells in your pancreas as like little insulin factories. Usually they only release insulin when they sense high blood sugar. It's a carefully regulated system.
A feedback loop.
Right. But quinine bypasses that sensory check entirely. It acts directly on the beta cells and forces them to dump insulin into the bloodstream, completely independent of what the blood sugar levels actually are.
Oh, wow. So it's like throwing gasoline on a fire.
Literally.
The malaria is already consuming all her glucose, her liver is failing, so it can't manufacture anymore. And then the doctor hooks up an IV drugs that floods her system with insulin.
Which drives whatever tiny amount of blood sugar she has left straight to zero.
That's a nightmare.
It caused severe, recurrent, refractory hypoglycemia. And in a patient who already has cerebral malaria, depriving the brain of glucose causes catastrophic additional neuronal injury.
So how did we finally figure this out and stop using it?
The medical community didn't fully wake up to this until two massive landmark trials were published. The Aquamat trial in adults in Southeast Asia and the Aquamat trial in children in sub-Saharan Africa.
What did they do differently?
They compared the old standard, IV quinine, to a newer drug called IV artesunate.
And the results weren't just a marginal improvement either, according to the sources. Artesunate reduced mortality by nearly 35% in adults and about 23% in children.
It was vastly superior across the board. Artesunate does not cause hypoglycemia because it doesn't stimulate those beta cells to release insulin.
Plus, it's faster, right?
Way faster. It clears the parasites so quickly, We see over a 90% reduction in parasite load in just 24 hours.
Which really highlights why another older kind of intuitive treatment was totally abandoned. Because the clinical notes mention that one of the doctors briefly considered an exchange transfusion,
Oh, right.
literally draining her parasite-filled blood out of her body and replacing it with healthy donor blood.
Like an oil change for the body.
Exactly.
Yeah.
If the blood is poisoned, swap the blood. It sounds completely logical.
It makes intuitive sense, especially before a drug like artesunate existed. But multiple systematic reviews eventually showed exchange transfusions offered no mortality benefit.
And they must be risky.
Massive risks. You're looking at volume overload and major hemodynamic instability. Artesunate simply kills the parasites chemically far faster than you could ever mechanically filter them out of the body. By 2015, the WHO completely abandoned exchange transfusions for malaria.
But there's a massive logistical hurdle here for this patient. A U.S. hospital can't just, send a nurse down to the pharmacy to grab a vial of artesunate.
No, most U.S. hospitals do not stock it at all.
Because it's so rare here.
Right. It is highly specialized and has a very short shelf life. To get it, the clinical team has to immediately call the CDC's Emergency Operations Center, which operates 24/7 to coordinate an emergency supply.
So they are literally racing against the clock, managing a crashing patient while waiting for the drug to be flown or driven in from a federal depot somewhere.
Yeah, the logistics are incredibly stressful.
And while they're on the phone with the CDC, this patient's body is failing in real time. She has a Glasgow Coma Scale, or GCS, of 9, meaning she's deeply unconscious. Plus, she's developing severe acute respiratory distress syndrome, or ARDS.
Her lungs are filling with fluid.
Exactly. So with a GCS of 9, standard non-invasive oxygen masks like a BiPAP machine, those are no longer an option.
No, the neurological depression means she can't protect her airway. If she vomits, she won't gag or cough. She will aspirate that fluid straight into her failing lungs. A GCS of 9 dictates immediate intubation.
But to put a breathing tube in.
Right. But choosing the right drugs to put her to sleep and temporarily paralyze her so they can slide the breathing tube in, that is just another minefield.
Because her blood pressure is already critically low. If they reach for standard propofol to put her to sleep, which a lot of people know is the white milky stuff used in basic surgeries, it acts as a vasodilator.
It widens the blood vessels.
Yeah, her blood pressure would bottom out completely and her heart would stop.
So they have to pivot to ketamine. Ketamine actually stimulates the sympathetic nervous system, which helps maintain or even boost her blood pressure during that super vulnerable intubation process.
Okay, so ketamine puts her under safely. But then they need a paralytic to stop her vocal cords from spasming while they insert the tube.
And the go-to in an emergency is often succinylcholine because it works incredibly fast.
But wait, the source says succinylcholine causes a brief spike in potassium levels in the blood.
Exactly.
And her kidneys are failing, which means her potassium is already dangerously high at 5.8. If they give her succinylcholine, it could trigger a fatal cardiac arrhythmia.
They recognize that landmine just in time and use a different paralytic called rocuronium instead.
Crisis averted.
For the moment. They get the tube in. But getting the tube in is only step one. Her lungs are failing so profoundly from the ARDS that she meets the criteria for a protocol based on the Perseva trial.
And what does that mean practically for the patient?
This means they have to physically flip her over and place her in a prone position, flat on her stomach, for at least 16 hours a day.
I think a lot of people heard about proning during the COVID pandemic, but mechanically, why does simply flipping someone on their stomach reduce mortality in severe ARDS by 50%?
It's all about gravity and anatomy. When a patient is lying on their back, the physical weight of their heart, combined with the inflammatory fluid building up in their lungs, actually crushes the posterior segments, the back part of the lungs.
Squishes them flat.
Right. And the problem is those posterior segments contain the most surface area for oxygen exchange.
So the best part of the lungs is being crushed.
Exactly. So by flipping the patient onto their stomach, you relieve that physical pressure. You recruit those undamaged posterior alveoli back into the breathing process, drastically improving how blood and oxygen match up.
But to keep a patient with a breathing tube perfectly still on their stomach for 16 hours, you have to keep them chemically paralyzed.
Because if they move, they could pull the tube out, which is catastrophic.
And this is where the multi-organ failure makes things incredibly complicated again. Her liver is failing from malarial hepatitis. Her kidneys are failing, turning her urine black.
Which raises a massive pharmacological question. how do you clear a continuous drip of a paralytic drug from a patient's body when the very organs responsible for filtering it out are broken?
Right. If they use standard ICU paralytics like rocuronium or vecuronium for this long 16-hour stretch, the drugs would just accumulate unpredictably in her tissues.
Yeah, they could turn the IV drip off the next day, and she might stay paralyzed for days because her body just can't clear it.
It's like trash piling up during a sanitation strike. The city's infrastructure is broken, so the garbage just accumulates on the streets.
That's a great way to look at it.
But there is a brilliant workaround for this, right?
Mm.
A drug called cisatririum.
Yes. Cisatricurium undergoes a unique process called Haussmann elimination.
Which is essentially a self-destructing message. The drug spontaneously degrades in the blood plasma simply based on the body's normal temperature and pH levels.
It completely bypasses the broken liver and kidneys. It is an elegant solution for multi-organ failure.
But there's a catch.
There's always a catch. Paralyzing a patient with cerebral malaria comes with a terrifying caveat. Neuromuscular blockade completely masks seizures.
Because the body physically cannot shake.
Exactly. The brain could be in continuous status epilepticus, literally frying from electrical storms caused by the blocked blood vessels and the high fever, and the patient would look perfectly still and peaceful on the bed.
Imagine being the family member sitting next to that bed. You think your loved one is resting peacefully, just breathing with the machine.
But without a continuous EEG monitor pasted to their scalp, reading their brain waves, you'd have absolutely no idea their brain is essentially on fire.
So the medical team has to mandate continuous EEG monitoring before they even start that paralytic trip.
Absolutely mandatory.
So they successfully navigate the intubation, they prone her, they monitor her brain waves, and finally the artesunate arrives from the CDC.
And they administer it, and it does its job. It chemically shreds the parasites. The follow-up smear shows the falciparum is completely gone.
You'd think the danger is over. The bug is dead.
Sure.
But the microscopic wreckage left behind creates two distinct delayed waves of danger.
Yeah, the battle leaves a mess.
And the first wave is what gives the case its title, Blackwater fever.
Right. When artesunate kills those parasites, or when the parasites burst out of the red blood cells naturally, it causes massive hemolysis.
That's the physical destruction of the red blood cells.
Exactly. And this releases an ocean of free hemoglobin into the blood plasma. Normally, specialized proteins in your blood bind up free hemoglobin, but those proteins are completely overwhelmed by the sheer volume of destruction here.
So where does it go?
This toxic free hemoglobin gets filtered by the kidneys, and it turns the urine that dark, alarming black color.
And it isn't just a scary color change. That free hemoglobin physically clumps together and creates casts. It's like microscopic concrete that directly damage and clog the renal tubules in the kidneys.
That is exactly why she has acute kidney injury. The clinical team has to aggressively hydrate her with massive amounts of IV fluids to try and physically flush this sludge out of the kidneys, all while prepping for dialysis if they fail.
And because so many red blood cells have been destroyed in this process, she desperately needs a blood transfusion.
Definitely.
Normally, in a modern ICU, doctors use a restrictive transfusion strategy, right? They wait until a patient's hemoglobin drops below 7 grams per deciliter before giving blood, just to avoid unnecessary risks.
Usually, yes. But for severe malaria, they target a higher threshold of 8.
Why make the exception here?
Well, there are 3 critical reasons. First, the hemolysis is ongoing. A level of 7 today will rapidly drop to 5 tomorrow.
Makes sense.
Second, remember the molecular Velcro? The brain's blood vessels are still physically blocked by the dead or dying parasitized cells, meaning the brain is starved for oxygen. Every single available red blood cell matters right now.
You can't run them low.
Exactly. And third, her ARDS is preventing her lungs from transferring oxygen efficiently into the blood anyway. You have to maximize her blood's carrying capacity just to keep her organs alive.
So they hydrate her, they transfuse her, and they navigate the Blackwater fever. She survives wave 1. Over the next week, she starts waking up, the breathing tube comes out, and she's preparing to leave the ICU.
Everyone is breathing a sigh of relief.
And this is where wave 2 hits. The week 2 trap.
Yeah, what's fascinating here is the mechanism behind the second trap, because it catches a lot of doctors entirely off guard. It is called post-artesunate delayed hemolysis, or PADH.
PADH?
Yes. It happens in about 25% of patients treated with artesunate, usually 7 to 14 days after they receive the drug.
long after everyone thinks the patient is completely cured.
Yes. Artesunate is incredible at rapidly clearing the parasite from the red blood cell, but the physical process of violently stripping that parasite out leaves behind what we call pitted or damaged red blood cells.
So the parasite is entirely gone, but the physical membrane of the cell is structurally altered.
Exactly.
They're essentially zombie cells just walking around the bloodstream.
That's a great way to put it. In the acute phase, when she's in the ICU, the spleen, which acts as the body's primary blood filter, ignores these zombie cells. It has much bigger problems to deal with, so it lets them circulate.
Okay, but later.
A week or two later, as the body calms down, the spleen suddenly recognizes that these pitted cells are structurally abnormal, and it begins destroying them en masse.
Wow.
A patient could be sitting at home feeling completely fine, and suddenly their hemoglobin plummets from 9 down to 6. And if an ER doctor looks at their blood then, they won't see any malaria parasites because the malaria is actually gone.
It's just the body's delayed cleanup process causing a massive secondary crash. That means mandatory weekly blood tests for a month after treatment, and the ICU team has to explicitly warn the primary care doctor to watch out for it.
Which brings us to the underlying tragedy of this entire case.
Right. We understand the cellular pathology, we know why the old treatments failed, and we've navigated the ICU interventions. But why did this happen to her in the first place?
Yeah.
She grew up in sub-Saharan Africa, where malaria is endemic. Shouldn't her immune system have known how to fight this off?
That's the assumption a lot of people make.
So what does this all mean? The context here introduces a concept that I think will shock a lot of you.
Yeah.
The VFR traveler, visiting friends and relatives.
It is arguably the single most dangerous epidemiological trap in imported malaria cases. When someone grows up in an area where malaria is endemic, their body survives repeated childhood infections and develops a partial immunity.
It doesn't prevent them from getting infected entirely, though.
Right, but it keeps the parasite levels low enough that they don't develop the severe, life-threatening complications we just talked about.
But that immunity is not a permanent shield. It acts more like a muscle that atrophies if you don't use it.
Yeah.
Within just 6 to 12 months of leaving an endemic area, that acquired immunity wanes significantly.
Because the immune system is no longer getting that continuous microscopic stimulation from repeated mosquito bites.
And this patient had been living in the United States for 8 months.
Her childhood immunity was effectively gone.
And this is the trap for VFR travelers. They immigrate, live in a place like the US or Europe for a year or two, and then go back home to visit family.
And they mistakenly believe they are still immune because they survived the mosquito bites as kids, so they don't bother taking malaria prophylaxis pills.
As a result, VFR travelers represent a wildly disproportionate fraction of imported severe malaria deaths. They travel with the biological vulnerability of completely naive tourists, but with the false confidence of a local. It is a fatal combination.
It really is.
So if you or someone you know immigrated from an endemic area and you are going back to visit, you must understand this. You are functionally semi-naive. Your childhood immunity has waned. You absolutely must take chemoprophylaxis.
Drugs like Malarone, doxycycline, or mefloquine.
And note, you cannot use chloroquine because there is widespread parasite resistance to it in sub-Saharan Africa.
It is a critical conversation that every primary care physician needs to have with their traveling patients to prevent cases exactly like this one.
It really is incredible how this single clinical case covers so much ground. I mean, we started in an ER with a misleading blood smear that looked like a minor traffic jam, but was actually a catastrophic molecular roadblock in the brain.
A total system failure.
Yeah. We saw the dark, black urine of kidneys failing under the weight of destroyed blood cells. We unpacked how a standard, trusted treatment like quinine was actually a pharmacological Trojan horse.
Forcing the pancreas to release insulin and actively harming patients for 40 years until artesunate finally replaced it.
And we navigated the incredibly tightrope of critical care, figuring out how to paralyze a patient without masking silent electrical brain seizures and utilizing a self-destructing paralytic drug because the liver and kidneys simply couldn't clear it.
It really highlights that critical care isn't just about fixing the immediate problem, it's a giant chess match. You're managing failing systems while trying to dodge the delayed trap set by the dying disease.
Which brings us back to that week 2 trap, PADH.
Right, and the mechanism of PADH leaves us with a truly profound realization. Artesunate is undeniably a miracle drug. It won the Nobel Prize.
It saves hundreds of thousands of lives.
By violently chemically stripping the parasite out of the red blood cell. But in doing so, it leaves behind those pitted, structurally altered zombie cells. It cures the immediate infection, but sets the stage for a delayed crisis.
The spleen's delayed reaction suddenly waking up and destroying the altered cells a week later.
It makes you wonder, what other miraculous medical treatments might be leaving microscopic time bombs in our bodies?
Oh, wow.
Scenarios where the cure alters our cells just enough to trigger a delayed civil war with our own immune system, weeks or even months after we think we've been perfectly healed.
That is a wild thought to sit with. Sometimes the body's delayed accounting of a cure can be just as dangerous as the disease itself. Thank you for diving into this incredibly complex medical landscape with us today, and a huge thank you to you for bringing us such rich source material. Keep questioning the consensus, keep looking past the obvious smear, and we'll see you on the next deep dive.